Pregestational endocrine counseling, which I am actually going to deal with. So this topic will be dealt in the next 12 minutes in these following headings. I'll share some information, some new insights, why it is indicated in our field, and what are the implications of doing this correctly. Tons of gratitude to all the organizers as well as my mentors, which I would like to acknowledge to my dear Dr. Sanjay Kalra, Dr. Usha Sriram, Dr. Ushti Tu, and from the Endocrine Brigade. So this topic, I should know, you should all know what is it, why is it, and how it is done for preconception care. And we should have healthy minds and bodies as well as healthy moms and babies. That is our aim. I have taken my slides from basically from one book, which is from Update on Endocrine Disorders During Pregnancy, in which the group has detailed told about the importance of preconception care. So trivia question to you, because if you are able to answer it, it's great. When was it recognized by American Congress of Gynecology, ACOG, the importance of preconception counseling? So is it A, 1990, B, 1995, C, 2000, or 2015? I just wanted to make it interactive. If you are able to answer it, it is great. The answer is actually 1995. The first technical bulletin on preconception care was published in that year, emphasized the importance of identifying the risk, providing individualized education, initiating desired interventions. ACOG continues to provide the recommendations on preconception care. So it's a leader in this field, though we know it's important. The first technical bulletin was published in 1995 May. So pregnancy takes into account two major factors: the partners involved, that is the male and the female, the husband and the wife, you can say. Nearly half of 200 million pregnancies that occur annually are actually unplanned pregnancies. So they happen by chance. They may have a reproductive life, but they may not be planning it on time or planning it on purpose. So preconception counseling can play an important role in reducing the poor prenatal or perinatal outcomes. Data is alarming. From US, it showed 35% of pregnancies are unplanned as per the Hewitt et al. 2010. It's actually even more as per the Indian data as well. So what is this preconception care or pregestation counseling? So preconception care is the care before pregnancy. It indicated to identify the medical and social problems prior to conception. It's basically a public health problem. It focuses on the prevention of and interventions to promote healthy pregnancy and outcomes. The three axes involved are optimizing the health by nutrition, avoiding addictions, ensuring a proper activity, addressing the modifiable risk factors, as our previous speakers have already mentioned. Finally, our job does not stop there. We should provide education, and that too quality education, to all our clients, customers, or our patients. We definitely want the patient's health to be optimized for pregnancy. So vitamin and mineral supplements have to be given on time, that include folic acid, iodine, zinc, and selenium, because we know that this is important to prevent the harm of neural defects, and we should definitely initiate these things quite early to prevent the comp and the dangers of smoking, because still we all know that, but even passive smoking is almost as harmful as their active smoking. Increase of artificial or assisted receptor techniques, it increases the risk of pregnancy complications and adversely affects the baby's health. Preconception health was studied in UK in about a sample size of 1,074 and showed that clearly there is an importance of planning pregnancy, and they see the health providers before pregnancy, and they stop all these addictions prior and even start what doctors had recommended. But data on India is lacking, and most important, we have to do it in our own area of interest. Let us see some case scenarios which I have prepared for you to optimize the preconception health for a healthy pregnancy journey. Hyperthyroidism and hypothyroidism both involve the axis, and they involve multiple organs. The developing fetus is also important. The thyroid symptoms may be variable. The TSH axis may be difficult to adjust, and we should start fertilization. Definitely for them, the TSH level is less than the routine TSH cutoff. We usually practice TSH of less than 2.5 when antibody is positive. Antibodies are chemical which is important to understand in the thyroid physiology as well, around that number. But definitely it should be optimized prior to pregnancy, because as you can see in this picture, the formation of HCG and finally iodine should be properly taken in the salt also. Hyperthyroidism in the womb is dangerous because the newborn also will suffer from the Graves' disease. And the antibodies cause the placenta to the fetus, causing the fetal damage to the tissue also. That is why you should always check the TSH before pregnancy plan. And if you are find that this may lead to some complications and fetal loss as well as fetal morbidity. In those with diabetes, especially the type 1 diabetes, you should look for autoimmune causes as well as treat the hypothyroidism and lead to fertility issues as well as risk of spontaneous abortion. So many children with hypothyroidism, cretinism, mixed edema, coma, all these things were there. And this has reduced by universally screening the babies for congenital hypothyroidism, as well as screening the mothers for TSH values. So replacing thyroid is adequately important. Preconception, you can see this wonderful graphic published in 2013 from US article showing that majority of those patients which you are given proper counseling do not achieve the recommended preconception and early gestation TSH despite our maximum efforts. And we all know that the value mentioned is 2.5, and studies in larger cohorts will be required to confirm this finding. So the first trimester, second trimester, third trimester, you can see adequate replacement is seen only less than 20% or less that time. Second trimester, you can find nearly 45, whereas third trimester, it improves to more than that number. So in diabetes, which you all know is the major killer, so you know that the placenta barrier, the crossing of the fetal, you can see that the fetal hyperglycemia can in turn lead to hyperinsulinemia. This can disorder the fetal growth, leading to fetal anomalies. The HbA1c, the cutoffs are told to be around 5.8 to 6.5. If you are ensuring it's in this range, risk of anomalies are definitely reduced. If you adequately control the diabetes early, we can prevent these ones. This is the neural tube deficit, which is definitely a marker of poor glycemic control. Detailed ocular assessment is required because if you find retinopathy present, we need to treat them before you go for a pregnancy, and we should definitely stabilize them and understand the risk of worsening during pregnancy also. So I'll just take you a guideline here. 2025, a guideline was mentioned by ADA, and it shows the standard of care in diabetes. The technologies have advanced from the glucose meters to continuous glucose monitoring. You can see in this picture on the left-hand side, a lady has worn a small device which takes you the sensor. It takes the values of glucose control over the 14 days to 30 days period. And that can show you short-term diabetes care control rather than the HbA1c, which shows the 3-month average. So 6 months before conception, ideally assess the complications if you have a diabetic lady, type 2 diabetes mother. There's overt diabetes, we call it overt diabetes. And if you're finding before conception, ideally target the value of less than or equal to 6.5. And teratogenic medicines have to be stopped and changed to safer medicines. And then you should institute metformin or insulin, which are basically safe medicine. Start the folic acid, iodine, and encourage them to lose the weight and to ideal body weight. In case of type 1 diabetes, it is simple. Insulin is the only mainstay, and you should ensure that targets of CGM, that is the continuous glucose meter values, are in range. It's called time in range. Time in range of more than or equal to 70% is required for them to be told to be accurate. In pregnancy, the cutoffs are mentioned 63 to 140 in the time in range in type 1 diabetes. And I'm above range is more than 140. You should remember the units when you are working in abroad, it is millimole per liter. And if it is India, it is milligram per deciliter. So the trial was called concept trial, which showed that CGM in pregnant women with type 1 diabetes provided an index of controlling the metabolism, metabolic activity, as well as the control and reducing the perinatal morbidity in this group of patients. And time in range is a wonderful indicator which CGM provides. The previous lecture, we heard about gestational diabetes. The vicious cycle of diabetes in gestation can be important to understand because the PCOS, preeclampsia, and obesity are the forerunners. And in the future, you can have an infant of women of gestational diabetes having epigenetic and genetic predisposition to obesity and future childhood diabetes or adulthood diabetes. So gestational diabetes provides a window of opportunity when you screen the woman in overt diabetes, in non-diabetes as well, in less than 13 weeks of gestation for early onset of gestational diabetes. And this can be done by a fasting plasma glucose, an HbA1c, or even an untimed random plasma glucose. A DIPSI method, this DIPSI recognizes that we can even do a random GRBS as well. So preconception care of diabetes in women is definitely understood. We should counsel them, understand the ocular and renal mechanism, stabilize the thyroid function, screen for the risk factors, aim for weight reduction, and control the blood sugar and the glucose and the BP before in advance. Start the folic acid, avoid the teratogenic agents like AC inhibitors, ARB, and statins, and consider the alternative medicines for this case. Overweight and obesity is the next case, definitely multifactorial. It is stigmatized and they are associated with longer time to pregnancy, especially the PCOS ladies, infertility and pregnancy outcomes, and even the lower chance of success with the ART techniques. So, overweight obesity ladies can also lead to other complications of cardiovascular outcomes and the postpartum outcomes, and including the fetal outcomes. That is why Institute of Medicine has revised the guidelines and mentioned that pre-pregnancy BMI should be taken into account when you have the patient going in for pregnancy and having a total weight gain. So total weight gain is as per the pre-pregnancy BMI, assuming that you have a 0.5 to 2 kilogram weight gain in first trimester. The next two trimesters ensure that they should be within or around this range of targets. And maternal obesity can even lead to the future issues of transgenerational issues, and we call it as transgenerational karma. So, whatever the mother does in pregnancy can reflect in the future in the child's insulin resistance, hypertension, and future risk of cardiometabolic disease. This is called the Barter hypothesis. Nutrition therapy is required to achieve the weight gain targets. We do it for overt as well as gestational ability with all these important steps. I'll just put a mnemonic for you for simplification. It is called ABCDE. Anemia should be stabilized, behavior should be optimized, avoid substance abuse, that's what behavior I told, and starts activity, physical activity as well. Blood pressure should be optimized as well as the weight, we call it as circumference. Then the diabetes and dental health, both should be stabilized. I deal with endocrine aspects, we stabilize the TSH and other factors. Also, remember the mother's or the partner's psychological or psychosocial health. The preconception care, my dear friends, certainly makes a difference. It prevents the birth defects, it prevents unplanned pregnancies, and makes the family better by reducing the maternal morbidity mortality, as well as preventing the preterm birth and low birth weight. We are all working in a place we need to understand the barriers that exist at the provider level, the organization level. And there is also a scope to understand endocrine disrupting chemicals and the risk of gestational hypertension and preeclampsia. Address this early because chemicals like BPA, PHT, PFAS are all EDCs. Now, to stop you, they are known to happen. These include the TTI or your water containing plastics or DDT containing the chemicals in your area. So we should try. A study was done in this, the electronic health records and all. They studied the index of BMI, genetic history, immunization, infectious diseases, medical history, exposures, mental history, nutrition, oral health. It's a comprehensive checklist which they did. And they definitely found innovative. This is done in 2019 or so. And they have published this. This is the first healthcare model PCH study. The Australian government has also recognized the importance of the preconception care and given it for general practitioners to prevent this in their client area. So we should definitely be supportive and give them specific, measurable, realistic, achievable, and time-specific cutoffs. Endocrine organs are far and beyond. Definitely, I've only addressed thyroid and pancreas, that is the diabetes. But you remember that pituitary, adrenal, ovary, gonadal issues also exist, which definitely needs another class by itself. We should give them clinical practice tips. One of the measures in US was the one key question. Ask them about intention for pregnancy, whether it is yes or maybe. Offer them a checkup. If it is no, then discuss the reliable contraception methods. This helps you having a clarity of thought as well. And even empower the family physicians with checklist. This is from John Hopkins University, which has mentioned preconception counseling and checklist for these conditions in their websites. So, summarizing my talk, dear friends, preconception care is a critical part of healthcare for the women of reproductive age. It includes some specific tests and treatment of conditions, but all want to include the health promotion. We want to reduce the risk of problems during future pregnancies. There is a concept of first 1,000 days of birth that includes pre-pregnancy and to the 12 months post-delivery also, until the 2 years of age. So that is a wonderful concept which definitely we should implement. That is why the preconception foundation should be laid in each pregnancy. We should also share some resources with our patients, which I definitely feel that we should all do it in our own way and our own time of interest. So knowledge points, my dear friends, we should use our labs. We should have an endocrinologist in your center, AR team to help you recognize emergencies, as well as an educator. So educator bridges the barrier between all these things. So I thank you all for listening to me.